All right, I have something very serious to say. 3 out of 4 babies born with blue skin from cyanotic heart defects will make it to their first birthday. Sounds good, right? But here's what's going to blow your mind. Only about 7 out of 10 will still be alive by age 18. Let that sink in. These aren't just your NICU babies anymore. They're your pediatric patients, your teenage patients, your adult patients. And if you can't tell the difference between transposition of the great vessels and tetralogy of Fallot in under 10 seconds, you could miss the warning signs that their heart is failing. By the end of our chat today, you'll have a simple trick that makes remembering these 2 defects impossible to forget. In fact, it's something you can use on the floor tomorrow. Hey everyone, I'm Martha, and I'm ready to dive into these cyanotic heart defects with you. Are you ready? This is the Nursing Navigator.
Nursing Navigator's here. Wipe away those study tears. Hurst, review's got your back. Listen close, stay on track.
Let's be honest for a second. When you're studying pediatric cardiology, all these cyanotic defects start blending together, don't they? Blue baby, heart surgery, done, right? Wrong. These conditions are showing up on your NCLEX. And more importantly, these kids are your future patients throughout their entire lives. But there's a reason you keep mixing up transposition of the great vessels and tetralogy of Fallot. And once we fix that gap in your understanding, everything will click into place. Today, we're going to break down why these 2 defects confuse everyone, what the real difference is that matters for your nursing practice, and a memory trick so powerful that you'll never mix them up again. Not on NCLEX, not in clinical, not ever. Does that sound good? Let's go. So why do nursing students constantly mix up transposition and tetralogy? It's not because you're bad at studying. It's because of how similar they are. Let me show you. Both defects make babies what? Cyanotic. And both need surgery. Both have fancy medical names that sound complicated. But here's the problem. Textbooks throw anatomy terms at you without explaining what's actually happening inside the heart. This leads you to memorizing words instead of understanding the picture. And that's why you forget it 5 minutes after you read it. So let's fix that right now. Let's start with transposition of the great vessels. We're going to call it TGV for short. So say it with me. TGV. Now here's what's happening. The 2 main highways out of the heart, the aorta and the pulmonary artery, are completely swapped. Imagine if someone switched the signs on 2 highways. All the traffic going to the beach ended up at the mountains instead. Well, that's what's happening here. So let me ask you this. Where is the pulmonary artery supposed to send blood? To the lungs, yes. And where is the aorta supposed to send blood? To the body. But in TGV, they are switched. The pulmonary artery, which is supposed to send blood to the lungs, is hooked up to the left side, and the aorta, which should send blood to the body, is hooked up to the right side. Now, think about this for a second. Oxygenated blood just keeps going back to the lungs, and oxygen-poor blood keeps going back to the body. So what color is the baby going to be? Blue. Immediately after birth or within a few days. So write this down somewhere or type it in your phone. TGV equals blue at birth, only days to live without intervention. TGV equals blue at birth, only days to live without intervention. So let me ask you a critical question. If the oxygenated blood can't get to the body and the deoxygenated blood can't get to the lungs, how long does this baby have to survive without help? We're talking about a 48 to 72 hour window. That's right, days, not weeks, not months, days. This is a surgical emergency. But here's what makes this really dangerous, and this is going to be on the NCLEX. How does a baby with switched vessels even stay alive long enough to get to surgery? Well, I want you to hold that thought because we need to talk about the other defect first, because that's where this whole puzzle comes together. Now let's talk about Tetralogy of Fallot. Say it with me. Tetralogy of Fallot. We're going to call it TOF for short, TOF. This is where the confusion really starts because this isn't about vessels being in the wrong place. This is about having 4 problems all happening at once in the heart. Here's what I want you to write down or type. TOF equals 4 defects. TOF equals 4 defects. Think of it like a car with 4 separate issues: bad brakes, flat tire, broken steering, and engine trouble. All 4 problems make the car dangerous to drive, right? Yeah. In Tetralogy of Fallot, you've got 4 defects. And I promise by the end, you'll have a trick that makes this effortless. Here they are, and I want you to say these with me as we go. Defect number 1, ventricular septal defect, or VSD. Well, what is that? That's right, it's a hole between the 2 bottom chambers. So picture a wall with a gap in it. Defect number 2, pulmonary artery stenosis. Now, what does stenosis mean? Narrowing, that's right. So this is a narrowing that makes it harder for blood to get to the lungs. Think of a garden hose someone has stepped on. Blood is trying to get through, but it's squeezed. Defect number 3, overriding aorta. The aorta sits right over that hole instead of arising from the left ventricle where it should. It's like a drain positioned wrong over a sink. And then finally, defect 4, right ventricular hypertrophy. The right side of the heart gets thick and muscular from working too hard. It's like a bodybuilder's bicep, but it's not a good thing in the heart. So let me ask you something. If we have all 4 of these defects working together, what's going to happen to the blood flow? Let's walk through this. The stenosis makes it harder for the blood to reach the lungs. So deoxygenated blood says, hey, there's a shortcut. It takes that shortcut through the VSD hole and heads straight out of the body through the overriding aorta. So what color is the baby going to be? Blue, yes. But, and this is critical, here's the key difference from transposition. Tetralogy babies might not be blue at birth. It just depends on the severity of the problems. Did you hear that? They might be okay for months. Some are even pink at first and then gradually get bluer as the stenosis worsens. Let's take a second to go over that again because this is huge. Transposition babies, blue immediately, days to live. Tetralogy babies might be pink at first, months before surgery. That is your NCLEX gold right there. Write this down. TOF, they may be pink at birth, gradual cyanosis, months before surgery. Now, let's talk about what you're actually going to see when you walk into a room. Because knowing the textbook definition doesn't help you if you can't recognize these kids when you're standing right in front of them, right? Right. So let's start with transposition. The signs and symptoms of TGV. Baby is cyanotic from birth or within hours. No mixing of blood means no oxygen to the body. And emergency intervention needed right away. Now, here's where it gets interesting. How do we keep this baby alive long enough to get surgery? Well, doctors can order a drug called prostaglandin. And what does this drug do? It keeps a fetal blood vessel, the ductus arteriosus, open. So why is that a good thing? It's a good thing because now a little bit of blood can mix. Remember, if there's no mixing, there's no oxygen to the body. So we need that ductus to stay open until surgery. They might even do a balloon septostomy. What is that? They literally make a hole between the heart's upper chambers so the blood can mix enough to keep the baby alive until surgery. It's pretty cool, right? Now, what about surgery? Surgery happens within the first few weeks of life. It's called an arterial switch operation. With this, they literally cut and reattach those vessels to the correct spots. And here's the good news. With modern surgery, more than 98% of these babies survive their infancy. Now let's take a look at tetralogy, the signs and symptoms of TOF. The baby might be okay at first. And this is so different from transposition, right? Yeah. Then this client with TOF might start having TET spells or blue spells. And these are sudden episodes where they turn very blue. And this is especially seen with crying, feeding, pooping. They have increased intra-abdominal pressure. And older kids with tetralogy might even squat down after running. Why is that? Because squatting increases blood return to the heart and actually helps them feel better. This is a classic sign you need to know for NCLEX. And hey, you may even see clubbing of their fingernails. Why is that? Because of chronic low oxygen. Okay, now you understand the difference. But how do you remember all of this when you're stressed out taking a nursing school exam, the NCLEX, or even standing at a patient's bedside? Well, this is the part you've been waiting for. Here's your memory trick. TGV equals two great vessels that traded places. I'm going to say it again. Two great vessels traded places. That's TGV. You see, the vessels switch spots. That's transposition of the great vessels. Now think about this. TOF, Tower of 4. I want you to picture a tower with 4 levels stacked up. That's your 4 defects. Let me show you. Level 1, it's on the bottom. That's the VSD. So it's the hole in the floor. Level 2 is the pulmonary stenosis, which is the narrowing doorway. Level 3 is the overriding aorta, the misplaced drain. And then level 4 at the top is the right ventricular hypertrophy, so those thick walls. Now, make sure you write that down, put it on a sticky note, and test yourself tomorrow. When you see a cyanotic heart defect question on NCLEX, this is the trick that will pop right into your head. Now, let's talk about what you are going to do as the nurse. Because you see, NCLEX doesn't just want you to identify the problem, they want you to know what to do about it. So, with both TGV and TOF, we want to monitor oxygen saturation because these babies are at risk for hypoxia. I mean, what's the normal oxygen saturation for a newborn? 95 to 100%, right? But these cardiac babies, they may run lower. Some might be 75 to 85%, and that's their baseline. So it's very important to know they're normal. Next, we want to assess for signs of worsening. So what are we actually looking for? Increased cyanosis, increased respiratory rate, poor feeding, decreased activity, and even TET spells with TOF. We also want to prevent crying and agitation. And why is that? Because crying increases oxygen demand. You see, these babies are already struggling to get enough oxygen. And when they cry, they need more oxygen, but they can't get more oxygen. So we try to keep them calm. Also, support the family. This is scary for parents. I mean, their baby is blue and their baby needs heart surgery. So they need education and emotional support. Now, something that is specific to TGV is to administer prostaglandin as ordered, monitor for apnea because that is a side effect of the prostaglandin, and prepare for early surgery. Remember, this is within weeks. Now, specifically to TOF, teach the parents about TET spells. Demonstrate the knee to chest position. Encourage frequent rest periods and high-calorie feeds because these babies burn a lot of calories. All right, you now have everything you need to master cyanotic heart defects. Here's what matters the most. These babies, the ones born blue, are surviving because of nurses just like you. Nurses who know the difference. Nurses who catch the warning signs. Nurses who understand what's really happening inside that tiny heart. So you see, you're not just memorizing for a test, you're learning to save lives that will span decades. If this helped you finally understand cyanotic heart defects, please share it with your study group because we all succeed together. Now, I have one final question for you. Do you want more of these videos? If so, tell us in the comments which topics you'd like to discuss. Until next time, future nurses, current nurses, and retired nurses, That's all for this episode of the Nursing Navigator by Hurst Review.
Guiding you through from school to the floor, nursing news, careers, and so much more. Learning, growing, passing the test. With Nursing Navigator, you'll be your best. Nursing Navigator's here.